Syncope is like the bane of your existence as an emergency physician. It comprises a huge number. I want to say it's about 10% of ER visits. The majority of it is totally benign, but there's a few folks that have a horrible, life-threatening condition you absolutely cannot miss, and sorting them out from the benign is the real challenge of it. Like, I haven't been this hoarse all week, and I sit down here in this very quiet, kind of angry-looking closet. It's a very
Who knows what's going on in the world out there right now?
Yeah, it could be zombies. We have no idea.
Welcome to Medic Mindset. I'm Ginger Locke, and this is another episode in the Thinking series. You may recognize the voice of the guest in this episode. He's Dr. Jason Pickett, and he's been in previous Medic Mindset episodes, and he has a podcast of his own, the Austin Travis County Office of the Medical Director podcast. He's met enough Medic Mindset listeners to know we are a brainy bunch, so he doesn't hold back when we ask him to share his knowledge. Listen in as we hunker down in a tiny closet, we pretended the world was on pause for an hour, and downloaded his brilliant mind of all things related to syncope. Let's start with the definition of syncope.
The definition of syncope is a transient loss of consciousness associated with loss of postural tone, meaning you pass out and you fall down.
I was thinking about this because I'm like, well, you can have it while being seated, so I guess that would just be like slumping over.
It could, or if it happens like in the dentist chair, which happens fairly often, so they're sitting upright and they lose that vascular tone, they pass out, but they don't lay down. When you hit the dirt, then the perfusion to your brain gets restarted again. In the chair, if you're sitting upright, you pass out, that perfusion's not restarted, and then they have like a hypoxic seizure from that. Yeah. So a really common thing that happens, and it's just what happens when you pass out and you don't get to lay down immediately and restore that perfusion.
That explains why we often confuse seizure for syncope. Because the bystanders will tell you, like, no, they did a little twitching or something like that. What you just said is that people can have seizure-like kind of convulsing during syncope.
That's exactly right. But as you lose that perfusion to the brain, then you can have that brief seizure activity, which is why so many times syncope can be mistaken for a seizure.
So can we bite off one of the things I wanted to talk about, which is how would you differentiate whether someone had a syncopal episode versus a seizure?
Invariably, somebody has a syncopal episode, they had a little bit of tonic-clonic activity. Syncope, they may have some prodromal symptoms, like really brief. I felt tunnel vision, and that's them losing the perfusion to their retinal artery. Or they have feeling dizzy, lightheaded, feel like they're going to pass out. Seizures, they often, but do not have to, come with an aura. Strange smells, flashing lights, strange noises, that kind of thing. The aura can sometimes be helpful in teasing that out, but sometimes for a first-time seizure, there is no aura, or there was nothing that the patient recognized as the symptoms leading up to that seizure. And with syncope, you pass out, and you should return to immediate normal mental status after that perfusion gets fixed. You lay down, and then your brain is perfused again. You're awake, alert, and oriented. Postictal, you've got a period of time of confusion, of unconsciousness. That's not syncope. Now, the one exception being the patient I saw yesterday, she had an event. I still think it might have been a seizure, but she face planted right into the deck, just toppled like a redwood, face planted right on the sidewalk. Sometimes a minor traumatic brain injury could complicate that picture a little bit. But in general, syncope, you wake right up again and you're alert and oriented. Seizure, you have that postictal period, some confusion thereafter. There are some other things, weird head-turning movements, lip smacking, eye fluttering, those kinds of things that tend to be more associated with seizure. Also, incontinence. It's pretty rare to become incontinent if you have a syncopal event. And tongue biting. Also, anybody who drops, have them stick their tongue out at you and take a look at it, make sure they didn't bite that.
So you talked about this kind of ground level fall face plant. So that gives me a chance to talk to you, who in a previous episode you said that backboarding causes cancer.
Backboards cause cancer. They absolutely do.
This gives me a chance to hear from you. A standard syncope, right? Ground level fall. Maybe they did. There is evidence that they hit their head. How do you approach the decision-making of spinal motion restriction in that patient?
First, by a good exam. Doing good physical examination, see if they've got any midline bony tenderness, do they have any neck pain, do they have any focal neurologic complaints, even subtle ones. So this is somewhere that EMS as well as ER docs tend to get nailed, is the patient with a spinal injury that has a little bit of tingling in their fingers or something like that. They can feel, they've got good equal grip strength. They're like, oh, okay, the neuro exam is fine, but they do have neurologic symptoms. Other things, are they intoxicated or confused? So if they're still post-ictal, that counts as confused to me. You can't really fully get the greatest history on them.
And is that, just to interject, is that because the exam may not be reliable as far as neurodeficits, like peripheral motor sensory? They may just not be able to reliably report whether or not they have altered sensation or something like that?
That's exactly right. And there's the distracting injury, which it's in the position paper that was recently released by the National Association of EMS Physicians and the American College of Surgeons Committee on Trauma. They mentioned distracting injuries, but the research that I've seen on distracting injuries is there really isn't such a thing. If the patient's alert and oriented, then they're able to tell you if their neck hurts, if there was an injury. If you have a suspicion, they've got pain, they've got positive findings, anything like that, then perform spinal motion restriction, which includes securing them on, yes, a backboard's on that list, even though they cause cancer, a scoop stretcher, a vacuum mattress, or the ambulance cot. That does a sufficient job of minimizing movement. Now, somebody who has a fracture anywhere, I don't care if it's in your spine or your arm or your leg, you don't want to be moving it around all over the place. And it's the same thing with spinal fractures. You don't want to be unnecessarily bending and twisting them and so forth. So you try to minimize that movement, and that's really what spinal motion restriction is about.
Well put. I have a question, unless you've got follow-up stuff that we've already started that you need to round out.
The first thing I really wanted to say about syncope is that the vast majority of syncope is benign cause. It's a vasovagal response to something. It's orthostatic hypotension because they're a little bit dehydrated or they had a change in their medications or something like that. Those are the ones that lull us into a false sense of security. But there are a few red flags that should get you thinking, bad stuff here. Okay, so seizure in a previously undiagnosed patient that never had a seizure before, never had a diagnosed seizure before. So some of those findings that we just talked about with seizure would be among them. Beware the exercise-provoked syncope, especially in a young person. That is hypertrophic obstructive cardiomyopathy or Brugada syndrome or something like that that is potentially life-threatening. They definitely need a workup for that. It's easy to say that the 17-year-old guy that is at football practice or basketball practice and passes out, like, he's just, running too hard. Like, no. If it's exercise provoked, or they're doing basketball or they're having sex or whatever, that really should be worked up. Now, I'm not talking about somebody who's 20 miles into their marathon, right? They have a perfectly good reason to pass out at that point. And I'd be there by like mile 4, I'm pretty sure. But this is like normal exercise. Beware of focal neurologic deficits. Anybody who has syncope and has unilateral weakness, unilateral numbness, anything like that. Folks who have a headache at the onset of syncope, oh my God, this headache, and boom, they hit the ground. That is potentially a subarachnoid hemorrhage, so definitely need to work them up. Folks who are short of breath and that have syncope, think PE with them, and tachycardia or abnormal vital signs in general. A syncope, you lose that postural tone, you get to the ground, and everything should normalize. If their vital signs are still abnormal, then that should lead you down the path of looking for other stuff. In general, beware the syncope and syndrome, syncope and chest pain, syncope and palpitation, syncope and shortness of breath, syncope and headache, syncope and abdominal pain, syncope and back pain, stuff like that should get you thinking about some of those potentially life-threatening causes of syncope.
The first thing you were listening were structural abnormalities in the heart or dysrhythmias. Can you talk about the workup you would expect a medic in the field to do to discover some of that?
Sure. So getting a great history. What happened? What were you doing at the time? What symptoms did you have before this event occurred? Has this ever happened to you before? Have you ever passed out on the basketball court or while exercising? Next, a physical, full neurologic exam, pulses, vital signs, and an EKG. I think really the EKG is painless, it's non-invasive, it's cheap. Do it very easily. That can clue you into some things, but it does require some expert interpretation. It's not simply, are they having an MI? Now, certainly MIs can present as syncope and arrhythmias can as well, VTAC being the one that we really are worried about. But other things, pre-excitation syndromes like Wolff-Parkinson-White syndrome or Langerhans-Levine syndrome, if there are alterations in the QT, either a long QT or a short QT, both of which are associated with arrhythmias. Brugada syndrome or an epsilon wave that indicates a right ventricular dysplasia, an arrhythmogenic right ventricular dysplasia. So some of these other sort of less common findings we don't tend to be looking for when we're just looking for ST elevation MI are some findings on the EKG that you can get that can clue you in. So I had this 17-year-old kid who was in a car wreck. Talking to the paramedics, they say, actually, the car was in pretty good shape. He just drove off the road into a cornfield. There was really no damage, so airbags didn't deploy. And talking to the kid, he's like, I feel fine. No pain, no injury, anything like that. And I asked him, what happened to you? And he said, I don't have any idea. I'm on a rural road. I'm driving 70 miles an hour on the road, and then suddenly I'm driving 70 miles an hour in a cornfield. And I don't know what happened in between there. Like, oh, sounds like you passed out. And did so without warning, which is another red flag. Somebody who drops without any warning at all, then that does suggest an arrhythmia. Did an EKG, and sure enough, type 2 Brugada syndrome, and he got his AICD within the week.
If you're thinking the syncope was caused by something cardiac, a dysrhythmia or a structural abnormality or something like that, will you routinely use ultrasound in the ER?
It depends on the presentation, and it depends also on the skill with ultrasound. So most emergency physicians can do a fast exam, look for free fluid in the abdomen, look for pericardial tamponade, look for tension pneumothorax. It takes a bit more training to get comfortable with bedside echo, but if you can see wall motion abnormalities with that or structural defects, then that can be helpful as well.
How about heart tones?
This is an important thing. So aortic stenosis is a fairly common cause of syncope, particularly in the elderly, because it is universal in the elderly. And so aortic stenosis and subaortic stenosis, which is really the hypertrophic cardiomyopathy, those affect your ability to get blood out of the left ventricle, to eject blood from the heart. And if your aortic stenosis is so bad and your heart's just working really hard to push that blood through that narrow aortic valve, then that may decrease that perfusion to the brain as well. Listening to heart tones is very important. If you get that blowing systolic murmur, then that suggests some valvular disease. We say valvular disease in general, but really we're talking about aortic stenosis.
If the person was seated when it happened versus standing when it happened, does that help you start classifying, or does that raise your suspicions for some more than others?
So the person who's seated or laying down when they have their syncopal event, then it's less likely that it was a postural change. Now, if somebody was laying down, then they get up and then down they go. Then I'm thinking, okay, they lost some vascular tone and dropped, and maybe a little bit more benign. But if somebody's sitting there minding their own business, how were they positioned? Were they hunched over? Were they getting less blood flow back through their femoral veins because of the position that they were in? Or could it be something more worrisome, the PE, the arrhythmia, something like that? By itself, it doesn't say a whole lot, but as part of the whole picture of what happened, then that does help. Now, it's easy. The 20-year-old military recruit who's standing in formation and face plants onto the deck, and he's hadn't had much to drink that morning because he didn't want to have to pee, and maybe he went out drinking the night before and didn't hydrate very well and so forth. And then he's standing there and locks his knees, and that blood flow through those popliteal veins comes down to a halt, and then you lose your preload, then you lose your cardiac output, and then down you go. As an extremely common event.
For band people too, right? The marching band?
Absolutely. Marching band, yes. You do not want your woodwinds face planting. It's not good for them at all. It doesn't do any good for the embouchure at all to kiss the ground.
So if I suddenly passed out right now?
Oh, well, we're in a building full of paramedics, so I'm going to get somebody to help me out here first.
You're not just going to sit and think, why did that happen?
I probably would say, or for the listeners, I would narrate that as a Ginger just passed out. She is laying on the ground and twitching. The twitching, however, has only lasted for 10 seconds. This was likely syncope. Hopefully you wouldn't catch it in the editing afterwards. It would stay in the episode. If you're sitting here and boom, over you go, passed out. It depends on was there some emotional reaction or event that predicated that?
And that's vasovagal if it's emotional.
It is. So it's vasovagal is emotional. And what happens is you have an emotional event. Their vagus nerve fires off and slows down the heart rate, and over they go. Important to remember that vasovagal is a diagnosis of exclusion. It's benign, and we're not worried about it, but we have to address some of these other potential causes as well.
Can we talk about the vasovagal for a second?
Yeah, sure.
Because this comes up when we're doing live sticks for the first time in class. At least one out of the 20 to 30 students will have some type of kind of sweaty, I need to lay down kind of event. That doesn't make sense to me. If they saw blood and they're excited, why wouldn't they get a sympathetic response? Why do we vagal down when we're seeing something scary? Usually we do the fight, flight, or freeze thing. And so I wondered if it was, and maybe you can help me, this is just a theory, is it that we do get the sympathetic response, but then our parasympathetic maybe over-rebounds or something?
I don't think we know why the vagus nerve fires off the way that it does. And keep in mind that vagus nerve response will be a lot quicker than getting the signal to the adrenal glands to release epinephrine to then circulate through the body. That vagal response will happen immediately. And again, I have no idea why that is. I don't know what evolutionary advantage that conveyed to us that it's persisted within our DNA to do that. Okay, so Ginger hits the ground in front of me, and after the initial wave of panic that comes over me, verify airway, breathing, circulation, evaluate you for injury from the fall, do a neurologic exam. And I'm assuming you're awake at this point. If you're not awake, I just treat you like an unconscious person. You hit the dirt, you're awake afterwards. So evaluate you for injury, assess you for anything that happened on the way down. See what you remember about the event. Do you remember any symptoms that occurred right before this? Do you remember what happened? Did you go all the way out completely or not? Now, that's not that important. Somebody who actually fully syncopized, their differential diagnosis is the same as somebody who didn't. Did you have any symptoms beforehand? And then are you having any symptoms now? Part of the physical exam, full neurologic exam, and get into the past medical history.
I ran a lot of these syncope calls, as you said, that we run a lot of them. I kind of had script of things I would do on every patient, the EKG, the neuro exam, and I got a D-stick on these people. Why would I do that?
It's funny because if they were hypoglycemic, if they woke back up after being unconscious, then they got glucose or somehow mobilized some stores of it. But maybe they were a bit low and then they got up from standing and they dropped and they're still feeling woozy, etc. Then they're still having symptoms. Then hypoglycemia is on that differential, and that's just such an easy, quick thing. There's certain things like don't miss this. Hypoglycemia is one of those. Somebody passes out, just check sugar. Also helps you if their sugar is wicked high. Then is this somebody who's in a hyperosmolar or non-ketotic state and they're dehydrated? And that leads you down another treatment pathway.
Yeah, that's good. That's a good reason. I was thinking hypoglycemia at the time, but it actually makes more sense that the dehydration that would be associated with hyperglycemia. Going back to the EKG, is it fair to say every age, any complaint of syncope gets an EKG?
Yeah, I think that's reasonable. Your chances of you catching an arrhythmia on there is zero. But the chances of you picking up something else, again, with some of those more subtle findings, more chronic findings, left ventricular hypertrophy in the young person, the pre-excitation syndromes, the Brugada, the arrhythmogenic hyperplastic right heart, those kinds of things. The QT intervals changes, long versus short. And we're seeing now that a lot of our medications cause QT changes. It's all of them, it seems. A whole bunch of antibiotics, anything that treats nausea or psychosis lengthens the QT. So doing an EKG, always a good idea. Again, it doesn't hurt. It's super fast. It's cheap.
And continuous monitoring after that, because I guess you actually could catch someone braiding down or getting a little bit of a heart block or runs a VTAC or something. You
could, and it depends. You don't necessarily have to monitor every single person that has syncope. If you've got a great history in physical and, here's this young, healthy patient with no previous episodes, then we do the EKG and say, okay, you're probably going to be fine. I'll never say never, but usually if you think that arrhythmia factored into your differential somewhere, then just keep them on continuous cardiac monitoring. And that includes keeping them on monitoring from the ambulance into the ER till you turn them over onto the ER stretcher, because that is where patients love to decompensate, is right between the ambulance and the ER when you don't have them on the monitor, and then the nurse looks at you like you're an idiot and you're like, no, really, it was fine. The rhythm was fine. Like, well, they're in VTAC now. Patients do that. I don't know. They do that there between the ambulance and the room, or they do it in the CT scanner, otherwise known as the donut of death.
Along those lines, this is advice that was given to me is for somebody who's had syncope, a critical time for us is wherever you find them, in the couch, in the car, on the floor, any postural change, when you move them, things might change. I was given the advice, if you're going to put them on an EKG, put them on that before you start moving them. And it's just a guideline, but I think that medic had seen enough times where they try to pick the person up or stand the person up or move them out of the car that things just change because of the posture.
Could change because of the posture, or as they are working themselves off the couch as you're standing them up to pivot them onto the stretcher, then they just bear down a little bit and their rhythm goes down and they braid you down and say, oh, okay, now I know what's going on. That brings me around to orthostatic vital signs. Orthostatic vital signs are generally not helpful. The sensitivity and specificity are really poor, like 50 to 70%, so you might as well flip a coin. You can't effectively rule anything in or rule anything out with orthostatic vitals. It does a good job of proving what you kind of already know, like, oh, well, they look kind of dehydrated, and so I'll do orthostatic vitals, see, they're dehydrated. Overall, not terribly helpful for you in the acute setting. And what do we mean by orthostatic? So we're defining this orthostatic hypotension as a drop in the systolic of 20 or more points, the diastolic 10 or more points after standing for at least 3 minutes. And there's orthostatic reflex tachycardia, so a heart rate increase of 30 beats per minute or greater. The problem is, and I'm looking at this review here done by Spoonfeed, which is really great. If you go to journalfeed.org, sign up for the Spoonfeed. It's awesome. Every day, breakdowns of studies in your inbox, really quick and easy to read.
So they're like synopses? Yeah. They're spoon feeding you?
Exactly. Yeah, pretty much. Synopses, like, this is what we think of the study, or here's the good and the bad of the study and limitations. In this one that came out January 11th of this year, so orthostatic hypotension was present in 30% of patients over 70 years of age. It was noted in 25% of all comers to the emergency department, and was found in 50% of nursing home residents. So already orthostatic hypotension is there in a huge population. So whatever's wrong with your patient, they come in, they have orthostatic hypotension. It's like, well, maybe they just fell into this other...
The nursing home ones, you think they're saying that's their baseline?
Yes, and that's not surprising. If you're laying around all day, you'll probably notice you get up, you get a little woozy. And folks who are generally bedbound for most of the day, most of their life, and most of their daily life, then they may have a little more trouble as they get up. There was a review in the Journal of the American Medical Association that found that orthostatic vital signs did not have any diagnostic utility in determining dehydrated versus non-dehydrated patients, but it did reliably predict patients who had lost a significant amount of blood, like greater than 630 mLs of blood. So if you lost more than half a liter of blood, then orthostatic vital signs were helpful. Hopefully, if they've lost more than half a liter of blood, you've noticed it in some other way, like the black stools or vomiting blood or vaginal bleeding or on the CT scan when their aorta ruptured.
Let's talk about dehydration. A medic would discover dehydration from the story, the history of intake and output, and then the physical exam would be things like skin turgor, oral mucosa, conjunctiva.
Skin turgor is a very late sign. That's somebody who's sunken eyes, a dry mouth. The layperson could look at them and say, wow, you're dehydrated. The dry oral mucosa, I do find helpful. Conjunctiva, I find less helpful. General skin tone, general impression, like when I walk into the room and look at somebody, looking at their skin tone, like, you look like you're a little peaked.
Wait, say for the listener what Pickett is.
Like pale, but look like they don't feel good. Just don't look like they're a little bit pale. They look a little sunken, That's I can't give you a good definition. It's. I
know. I wanted to watch you squirm around with that one.
It worked. It totally worked.
This is the challenge of asking an expert to explain what they see to somebody who wants desperately to know what you're seeing. This is it. This is all the listeners get to hear. An expert not being able to put into words what they've consolidated.
That's very kind of you to refer to me as an expert, but
I didn't say an expert of what.
I'm pretty sure some of my academic colleagues are like amateur. So but they kind of don't look right to you. But what does the urine look like? They've got darkened urine. They're concentrating. They're not peeing that much. When we're talking to parents of young children, we say, how many wet diapers has the child had? And usually about 5 wet diapers a day is normal. As I found, generally that number of urines a day is normal for an adult too. So if you peed at least 5 times a day, yes, I have, and their blood sugar is not 400, then I feel okay about their hydration status at that point.
Since I know you've been tinkering around with ultrasound, I'm going to say a sentence, but it's the end of my knowledge at the end of the sentence. I've heard where you can look at the vena cava, the inferior vena cava, I believe, and get a sense of how full it is. You
can, and this is one of the findings that's taught. You take a look at the vena cava and you have the patient do a sniff test and you say, just sniff, like inhale really hard through your nose, like that. The idea is you suddenly decrease the intrathoracic pressure and more venous blood goes into the chest. So if the vena cava, if it collapses more than 50%, then there's not a whole lot of preload there because you just emptied all the preload into the chest when you did that sniff. If it collapses like 25 to 50%, then that's normal. And if it collapses less than 25%, then maybe they're fluid overloaded. That's the theory behind it. I think it has been debunked more recently in the literature. It shows it's maybe not as helpful or predictive as we thought.
Interesting. And that 25%, 50%, is that all qualitative visual estimate, or is it a number that somehow you're getting?
Oh, you actually measure the IVC.
The diameter?
Yeah, you freeze it and measure the diameter of the IVC.
All right. Neat. Thanks.
Sure.
Thanks for indulging that. I'm trying to learn all I can about ultrasound. I'm going to take a class. There's a group called EMS POCUS, Point of Care Ultrasound. They travel around and do classes, and I got to get in their class because it's the way things are going. I want to know before all my students know before me.
Well, there are some other things you will find on ultrasound that will be helpful in syncope. Getting a look at the heart, is there a pericardial effusion? So if you have significant pericardial tamponade, then that can cause syncope. If your right ventricle is blown out and it's not emptying at all, then you have to consider a PE because that right ventricle is pumping blood into the pulmonary arteries. If there's a big clot there that's preventing that flow, then that right ventricle is going to be dilated and not emptying out appropriately. If you have free fluid in the abdomen, so you have to consider things like ectopic pregnancy. Any woman of childbearing age with syncope gets a pregnancy test. If there's any possibility at all of pregnancy, then she gets a pregnancy test, and pregnancy itself can cause syncope, and then a ruptured ectopic pregnancy could be life-threatening. Looking at the aorta, looking for signs of AAA will be helpful. If you're really good at ultrasound, you can actually pick up some thoracic aortic dissections on ultrasound as well. It's not really the standard, for it, unless you're doing a transesophageal echo, which I don't really see us doing in the field in the near future. Sometimes when you get that suprasternal notch view down, and you can sometimes catch a thoracic dissection.
Like in the arch.
Exactly.
I was surprised at how close the aortic arch is to that anatomical location. In my mind, it would be more inferior, but it's just right there.
It is. It's funny because we think of it that way. I think because a lot of times we look at chest x-rays that are shot from posterior to anterior, in which case the clavicles, everything else is pushed lower on the image. So it looks like the aortic knob in the heart is lower than it actually is. But relative to the front of the chest, yeah, things are right up there.
Yeah, and I learned that when someone I know had a aortic aneurysm. One of his presenting signs, like in the months before they discovered it or the weeks before they discovered it, was this hoarseness that he had. Like it was just pushing on the structures of vocalization.
Now everybody's going to be going to the ER with hoarseness.
I'll delete that part.
It's just like, I'm hoarse. It might be a thoracic aortic dissection. I think you're going to be okay.
I'll delete that part.
You're 15 years old. You think you're going to be fine. Just, drink water. Take Motrin, change your socks.
The paramedic that does, we better go take you to the ER to get checked out routine. What are the important things that are more commonly done in hospital that we just don't have the tools for?
So that's a great question. And that medic who's like, well, we better take you to the hospital to get checked out. After an episode of Syncope, I think that's actually warranted. I think that's a good idea. If you know me, I'm not a, let's take everybody to the hospital kind of person. But in Syncope, because those other life-threatening diagnoses can present with syncope, it seems like every life-threatening thing, one of the presenting symptoms is syncope. What are some of the things that we're going to do at the hospital? When you're counseling a patient, they passed out like, no, I'm fine. I'm okay. I don't really need to go to the hospital. And not everybody who refuses transport do we have to terrify. We don't have to say, well, it could be this impending death and it's coming. You don't have to necessarily do that, but some shared decision-making and advising the patient that most of the time this is benign. It's a matter of just hydration or a little benign vasovagal thing, but every once in a while.
Yeah, that's why I asked the question, because my preference would be is that the medic says that and they know what, kind of have a sense of the additional tests that need to be run or things that they might investigate in the ER so they can coach the patient or the patient's family about that.
Things that we'll do a pregnancy test. We'll get a hemoglobin. You can have somebody that has a slow, smoldering GI bleed that they were not aware of, and their hemoglobin comes back and it's 6. You're like, oh, okay, so they not only need a transfusion, but they need significant workup for that blood loss. And making sure that there's not A, pregnancy, and B, it's not in the wrong place, and maybe that's why it's happened. Getting an ultrasound of the heart. Not all of the workup is necessarily going to get done in the emergency department. We may do some shared decision-making if the patient is medium risk, I'll say. I'm not going to say low risk, because the truly low risk, you just send them home, they're fine. But the medium risk patients, the 50-year-old that has type 2 diabetes, so they have some potential risk factors, some comorbidity, but that's not a slam dunk to admit them, then a little bit of shared decision-making with the patient and close outpatient follow-up with the cardiologist. Electrolytes may or may not be helpful. If I suspect something, sure. I do not like the whole just get labs for the sake of getting labs. You're in the ER, so I'm going to get labs. So let's not waste the patient's money. But if I think there's something there, then absolutely we'll get some electrolytes, check a kidney function. But the hemoglobin is a very important thing. When you're counseling the patient and they're not inclined to go to the ER with you, think about those red flags. The severe headache, the chest pain, the focal neurologic symptoms, the bleeding. Black tarry stools, been throwing up blood, vaginal bleeding, abdominal pain, back pain. So the syncope, and because that steers you more towards the potentially life-threatening illness. The syncope that occurs without warning. I didn't feel anything, I woke up on the floor and I have no idea how I got there. And first-time seizure. Not that first-time seizures are always scary. Most of the time they're really not scary, but we do need to work that out. Make sure it's not a tumor or bleeding or something like that that's caused that. So if they're completely healthy, they don't have a history of CHF, and their EKG is normal but doesn't show all these other things that we talked about, and if you don't know what WPW or lung-gonadal or long QT or short QT or Brugada syndrome or epsilon waves look like, then please look up all those things and make that part of your practice pattern.
I'm going to put that in the show notes, probably using the great website, Life in the Fast Lane, that's got rules for all of that.
They do.
Great reference.
That is an awesome website. And if the patient's not still symptomatic, so we've ruled out all of that kind of stuff, we still warn them, look, there's a lot of things that could be going on here that you don't know. And if you're elderly, that suspicion for life-threatening stuff goes way up immediately. You say, look, if these are some of the potential things that it could be nothing, but here are the things that I'm worried about that we can't work up in the field. Mm-hmm. Do you have a primary care doctor? Can I call them for you? Place that phone call to the PCP, express their concerns to the PCP. It's a lot easier when it's the paramedic that's calling and the doctor's like, okay, I'm getting a call from the patient, but no, I'm getting a call from a paramedic at my patient's house that has concerns and objective findings that we can talk about.
More likely to get them on the phone, don't you think? Like
yes.
A quick response.
Yes. I mean, usually outpatient doctors, the echelons of other personnel that work at the office do a really good job of protecting the doctor from the patient.
Yeah.
But it's easier
a good way of putting it.
As a medical provider, it's easier to pierce through those and, hey, this is paramedic so-and-so. I'm calling about one of his patients. I need to talk to him.
Right.
Then
that's kind of an unusual, dramatic phone call to get, I imagine, like at a typical doctor's office.
Happens more often than you might think, because you get calls from the ER all the time. Mm-hmm. Hey, I've got one of your patients in the ER. This is what we have going on, and I'd like to maybe see if you can see them in the office and we can avoid an admission, which is a very frequent strategy with syncope too.
Yeah.
So we'll get them out of here. Let's get them in your office, but we're ensuring that follow-up. That's the key thing. From an EMS provider's perspective, it is a lot of times harder when you're cutting them loose there because you really can't guarantee follow-up unless you've got a really good community paramedic system, your community health paramedics, CHIPs, like we've got here, where we actually can ensure some amount of follow-up. We can get some labs, we can get a home visit by the doc, that kind of thing. But if you don't have that, then that's really hard to ensure that kind of follow-up. And then you stress the potential bad things that could occur, and you encourage them to, if you change your mind, I definitely want to hear from you again. I would love to see you again. We'll be happy to take care of you. Mm-hmm. Make sure the patient doesn't think that you'll be mad at them if you come back.
Yeah.
Leave that door open for them. Mm-hmm. Or if you don't want to go with me, and I understand you don't want an ambulance bill, I get it, but at least if somebody else can take you to the hospital or to your doctor first thing in the morning or something like that, please do that.
The ambulance should just take them to the doctor's office.
So I think that's the direction that we're going with EMS. I think that send a big ambulance full of critical care capable paramedics to every single call, lights and sirens, and take every single patient to the ER. I think that model is going to die off for a large portion of our patients, and we're going to really more get them what they need. Mm-hmm. What do they need? We need to ensure follow-up, and we can use these outpatient resources. We can navigate this complex system of resources that we have to help patients, and I think we as EMS can do a much better job of that. Life-threatening causes of syncope generally will fall into cardiovascular, neuro, and bleeding, volume loss. So cardiovascular, arrhythmia is the big one. VTAC is the one that I was thinking about, potentially lethal arrhythmia, but also pre-excitation syndromes, WPW, think about those as well. Cardiac ischemia. So if you have an MI, then that can drop your cardiac output briefly or even cause a transient arrhythmia. Definitely don't miss that one. And then aortic stenosis or subaortic stenosis or HOCM, then those structural diseases are in there as well. So that's cardiac. When you get to vascular, thoracic aortic dissection or pulmonary embolism.
Why are you being specific to thoracic aortic aneurysm?
Usually with a AAA, we got some time, depending on how big it is, we may just manage it medically. But thoracic aortic dissection can cause a variety of other syndromes. So you dissect into the common carotid artery, you can cause a stroke along with it. So beware of chest pain plus stroke, right?
So you'd rather have an abdominal aortic aneurysm than a thoracic one?
I'd rather have neither one, to be quite honest. But if I was going to have one of them, I'd like to have the abdominal, and I would like to have it diagnosed early. You can also dissect into coronary arteries and cause an ST elevation MI. So about 1% MIs, STEMIs, are actually thoracic dissection into that. And unfortunately, most of the time, we'll do a chest x-ray to see if we can eke that out, and hopefully it shows up on there. But we don't really chase that down with CT scans and so forth because, again, it's 1%. So they go to cath lab, and it's like, I'm having trouble getting this wire into this coronary artery because it's dissected into it, and so they figure it out then.
1% is actually a lot because that's a pretty unique anatomical phenomenon, really.
And 1% to 2% is basically the commonly accepted miss rate in emergency medicine of various diseases. So we know that we are going to miss some diseases. We're going to miss some strokes. We're going to miss some MIs. We do the best that we can to make that number 0, but we know it's not going to be 0. At what point do we say, okay, we need to rethink what we're doing? If we're missing more than 1% to 2%, then we probably need to rethink things. So cardiac and cardiovascular, so arrhythmias, WBW, aortic stenosis also on that list, ischemia, HOCM.
What are you saying, HOCM?
Hypertrophic obstructive cardiomyopathy. So HOCM.
HOCM.
Hook'em horns. So then think your neuro stuff, stroke, seizure, subarachnoid hemorrhage. The person who has that thunderclap headache and passes out, that is a red flag for subarachnoid hemorrhage. They need a CT scan and possibly an LP. And then bleeding, ruptured ectopic, GI bleed, AAA, that volume loss. Now, there's the San Francisco Syncope rule, which sometimes helps us with patients in the emergency department. Unless you're doing point-of-care testing in the field and you're really good at EKGs, then it may not be as helpful. But we use this chest mnemonic. So C is for CHF, so any evidence of cardiac failure or history thereof. H is for hemoglobin of less than 30. E for EKG abnormalities. And again, that's not just ischemia, but it's those other things we talked about as well. S for shortness of breath. Again, if they had syncope and they have ongoing shortness of breath afterwards, that's not just syncope. They've got an ongoing problem. And then a systolic blood pressure of less than 90. So those 5 things, CHF, hemoglobin less than 30, EKG abnormalities, shortness of breath, systolic pressure less than 90, can help you eke out some of the patients that you really don't want to let go home. But by no means is that all of the patients with syncope that could have a potentially life-threatening issue. Clicking positive to any of those 5 will put somebody in a higher risk category as far as you're concerned, and then you're more likely to get admitted.
And with each additional one, it's additive, like more and more risk if you have more of those?
My take is if you've got one of those, then you're coming in. Any one of those by itself is sufficient. If you passed out and you're short of breath, then I'm admitting you.
Are you thinking
to the
PE
hospital.
there or anything else?
Exactly. Yeah, thinking PE or cardiac ischemia.
I've said this before. I think, I guess it was the chest pain episode with Brandon Blease. PE comes up so much more in talking to you guys than it ever did in my paramedic education. It seems like you guys are diligently screening for that.
My old chairman, where I went to residency, Glenn Hamilton, who is an amazing clinician, he said, you can never win with PE. It sneaks up on you in all these cases. And I can think of all these cases that I've had where I went down this path of working somebody up and there's a PE. I'm like, well, what do you know? There it is. And even had a mentor of mine, a good friend, a physician who's taught me a hell of a lot about everything in emergency medicine, had a PE. He had traveled, but he had flown, but it was not a long flight. We usually say like 3.5 hours is kind of the point where you start thinking about the car trip or plane ride being a risk factor for PE. He'd had a trip, but he hadn't it wasn't a particularly long one. And he got back to the house and he's like, I just felt achy. I just felt achy all over the body. And he was carrying the bags upstairs. He said, I'm halfway up the stairs and it just hit me like a freight train. I had to sit down for a moment on the stairs. Caught his breath and then resumed, took him upstairs. He's like, oh, thank God my wife didn't see me because then she would have had me go to the hospital immediately. He then worked 2 shifts in the emergency department and then got home and is like, okay, I need to go to the hospital. Tells his wife, you got to take me to the ER. Sure enough, had a big PE, actually bottomed out his blood pressure, was in ICU, was deadly, deadly sick. Here he is, an extremely astute clinician, and PE snuck up on him.
And they can be slow like that? is the word chronic? If it's lasting over 2 or 3 days, it's just not getting worse?
Well, the clot can propagate, or you can cut loose more clot from where it originated. Clot tends to beget more clot and then get broken down. But if you throw that big clot in your leg into the lungs and then more clots start showering up that way, then yes, you can certainly get worse.
But how did he last so long? Like 2 days? Was it small enough that it didn't?
Well, I think it's because he's tough as a bag of bricks, I mean, the guy's hard as woodpecker lips is part of it, I think. The initial PE, it may be devastating if you have a giant saddle embolism that goes in and becomes immediately hemodynamically significant, but it may not. You may get smaller PEs that get thrown in there, and they're not that hemodynamically significant, or you compensate very, very well, and then after a period of time, your body's like, okay, I'm tired of this. I can't do this anymore.
Okay.
I can't do it anymore. I can't. You ask so much of me and give nothing in return. There's your soundbite.
Thanks. Thank you for the time. Thanks for finding the closet.
Yes, we got to get a picture of us in the closet together. Yeah, well, thank you so much for having me on the show again.
Yeah.
I always enjoy talking with you, and this is a lot of fun.
It's great having you in town. Maybe you'll just be my regular guest.
That I am totally cool with that. We'd be like peanut butter and jelly right here, like Starsky and Hutch, like Riggs and Murtaugh.
Keep going.
Like a Firefly Doctor Who crossover. That's how cool that would be.
Thank you to Michael Herbert for making the cover art for this episode. Feel like growing your creative brain? Every episode of the Thinking series features original art from medics. So if you want to play, send me a message and let's make something together. You always make me laugh at bad stuff.
That's terrible, which you have to edit out, please.
Last time I laughed at the doc that was a mentor that had polio. Remember that?
Mm-hmm.
Remember me laughing at that?
I do.
I think you left it in.
I did. I'm so sorry.
Do you want to hear yourself?
Yeah, it's funny. I asked my dad about this, who does voiceover. And
Your dad does voiceovers?
Yeah.
That's his job?
Yeah. And I asked him, I was like, what do you think? Headphones or not? He said there's two schools of thought on this. One school is always use headphones. The other school is never use headphones. It helps me make sure that I'm maintaining that distance.
I think I don't project as much because I can hear it so easily right here. Like, oh, it is.
Yeah, if you're right up here. That's true. You'd be like Jocko Willink, who just talks like with his face right on the microphone. He's like, you feel bad? Good. Choke yourself.